Good evening, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinars, which are part of our diabetes mini-series. We will have two sessions tonight. The first is entitled Addressing the Bidirectional Link Between COVID-19 and Diabetes, with our first guest speaker, Dr. Krysta Shannon. Our second session is entitled Inpatient Considerations for the Management of Hyperglycemia and Diabetes Mellitus by Dr. Emma Studlak. Dr. Krysta Shannon is a clinical pharmacy manager in internal medicine at New York Presbyterian Lawrence Hospital in Bronxville, New York. She is originally from upstate New York and received her Doctor of Pharmacy degree from Albany College of Pharmacy and Health Sciences. She completed her PGY1 residency at UMass Memorial Medical Center in Worcester, Massachusetts, and recently completed her PGY2 residency in internal medicine at New York Presbyterian Hospital. Her professional interests include diabetes and addressing healthcare disparities, specifically those uncovered by the COVID-19 pandemic. Dr. Studlak has been a clinical assistant professor at D'Youville University School of Pharmacy in Buffalo, New York. Dr. Studlak completed her PGY1 pharmacy practice residency and PGY2 internal medicine residency at Buffalo General Medical Center after earning her Doctor of Pharmacy degree from Wegman School of Pharmacy at St. John Fisher College. She is a board-certified pharmacotherapy specialist, and her areas of interest include internal medicine, cardiology, anticoagulation, and transitions of care. Her clinical practice site is Mercy Hospital in Buffalo, New York, where she practices as an internal medicine clinical pharmacist with a medical teaching team, and she also precepts pharmacy students and residents. Dr. Studlak is active in local, state, and national organizations and is a past president of the Western New York Society of Health Systems Pharmacists. Before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in a resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. And the CE code for this program will be provided at the end of the program. And with that, I'll turn it over to Dr. Shannon.
Good evening, everybody. Thank you so much for joining me as we talk about one of my areas of interest, which is addressing the bidirectional link between COVID-19 and diabetes. So we'll start out the discussion tonight with a roadmap of what we'll talk about, and we'll start by reviewing the pathophysiology of metabolic disturbances in COVID-19. Then we'll go on to describe the bidirectional interplay between COVID-19 and diabetes. We'll discuss outcomes associated with glycemic control in our COVID-19 patients in order to establish the clinical importance. And then lastly, we'll apply glycemic control strategies to our patients with COVID-19. So this first slide here provides an overview of the COVID-19 pandemic, which unfortunately is all too familiar to many of us working in the medical field. I just wanted to emphasize a few key points on this slide. The first being the distinction between the SARS-CoV-2 virus and the COVID-19 disease itself. So just highlighting that the SARS-CoV-2 virus actually leads to the COVID-19 disease. I also wanted to highlight that severe disease mainly occurs in older adults and those with comorbidities such as hypertension, cardiovascular disease, chronic lung disease, cancer, and chronic kidney disease. And then, of course, the focus of our presentation today, which will be diabetes. So whenever talking about the pathophysiology of COVID-19 on more of a molecular level, it's important to link it back to the RAS system. So when the RAS system is activated, we see that angiotensinogen produced in the liver is cleaved to angiotensin 1 in the kidney. In this figure here, you can see that angiotensin 1 is further converted to angiotensin 2 by the ACE enzyme. And then angiotensin 2 binds to its receptors, AT1R and AT2R, causing the release of aldosterone from the adrenal cortex. And the second part of the RAS system on the right-hand side of the diagram, angiotensin 2 is converted by ACE2 to the vasodilatory angiotensin 1 through 7, which then go on to bind to the MAS receptor. So ACE2, angiotensin 1 through 7, and the MAS receptor constitute the vasoprotective, anti-inflammatory, and antifibrotic arms of the RAS system. But we can see that when our ACE levels become too high and the ACE2 receptor is inhibited, that we see a shift in the balance towards the pro-inflammatory and the increased release of aldosterone, the pro-inflammatory side of this RAS system. And this is often what happens in severe COVID-19 disease. And this is often when we see this imbalance that leads to the severe end organ damage in severe COVID-19. Focusing in on the ACE2 receptor a little bit closer, the ACE2 receptor serves as a cellular entry point for the SARS coronavirus. And the ACE2 receptor consists of two forms. We see a membrane spanning protein, as well as a circulating soluble form, both of which are capable of binding to the spike protein on the surface of the SARS-CoV-2 receptor. The ACE2 receptors serve as a cellular entry point for all SARS coronaviruses. So this is not just specific to the SARS-CoV-2 virus. Actually, all coronaviruses are able to bind to this receptor. And the ACE2 receptor is expressed on pancreatic islet cells, and through which it facilitates entrance of the coronaviruses, including the SARS-CoV-2 virus. So entrance of the SARS-CoV-2 virus into these pancreatic islet cells disrupts glucose metabolism. And there's also some data to suggest that patients with diabetes have increased expression of ACE2. So following infection with SARS-CoV-2 virus, the viral spike protein is cleaved by this TMP-RSS2 protein, and the membrane form of ACE2 is internalized with the virus, leading to a decrease in ACE2. So this stage might result in overactivation of the ACE or angiotensin 2 part of the RAS system, thereby augmenting signaling through the AT1R and the AT2R receptors. The direct binding of the SARS-CoV-2 to ACE2 on beta cells might contribute to beta cell damage and insulin deficiency, which overall contribute to worsening glucose control. Additional metabolic complications commonly arise from adipose tissue in obese individuals, and unfortunately, diabetes and obesity often go hand in hand. So in the white adipose tissue of individuals with obesity, adipocytes are hypertrophic, and the tissue is infiltrated with pro-inflammatory immune cells that secrete cytokines and chemokines, leading to a permanent inflammatory phenotype. In diabetes, insulin resistance also leads to an increased infiltration of M1 macrophages into the adipose tissue. And following infection with SARS-CoV-2, this chronic inflammation might aggravate COVID-19 symptoms. And therefore, we see an overall meta-inflammatory state and cytokine storm, again, contributing to some of the common complications, including damaged blood vessels. We see coagulopathies in these patients, and relating specifically to diabetes, we often see peripheral insulin resistance. The SARS-CoV-2 virus itself can also induce metabolic reprogramming in some of the pathways that are involved in energy production and immune response. So listed here are some of the metabolic pathways that are altered when a patient becomes infected with COVID-19. So first, starting off with the amino acid pathway. So over the course of SARS-CoV-2 infection, alterations of amino acid metabolism, including various amino acids such as tryptophan, arginine, and glutamine, occur, and these all result in dysregulated immune response and assembly of the progeny virus. We also see that metabolites of glycolysis have been COVID-19, which are indicators of enhanced glucose metabolism for lactate fermentation. And this enhanced glycolysis results in sustained cytokine production and an overall inflammatory state, leading to T cell impairment and lung epithelial cell death. And then lastly, we see that the metabolic pathways of cholesterol and fatty acids are also altered in COVID-19 disease. And these are used to consume, or these are consumed to facilitate viral entry into cells. Therefore, we see impaired cellular function because the virus is consuming these, and some of the normal functions of cholesterol and fatty acids, such as maintaining the integrity of cell membranes, are disrupted when a patient is infected with COVID-19. So we'll pause here for a moment for our first polling question. Which of the following receptors, or which is the primary receptor implicated in COVID-19 induced metabolic derangements? Is it ACE, ACE2, AT1R, or AT2R? Okay, great. It looks like 85% of participants chose ACE2 or B, which is the correct answer. So if you recall, following binding of the SARS-CoV-2 virus to that ACE2 receptor, the receptor is internalized by that infected cell, leading to a distinct downregulation of ACE2, which constitutes the vasoprotective arm of the RAS system. The other receptors here are also implicated, but there are more so downstream effects of that ACE2 receptor being targeted by the virus. Okay, next we'll move on to talk a little bit about this bidirectional link between COVID and diabetes. So over the past couple of years, several studies have suggested a bidirectional link. So on one hand, we have patients with pre-existing Mellitus who are at an increased risk of viral infection. And this does include COVID-19 disease due to alterations in their innate immunity that we'll talk about in greater detail a little bit later. On the other hand, patients with no history of metabolic disease or diabetes who contract COVID-19 disease are presenting with new onset diabetes and severe metabolic complications, including diabetic ketoacidosis. So first, we'll focus on the increased susceptibility to infection in diabetics and why they're more prone to progressing to severe disease. So several studies suggest an increased risk of infection among patients with diabetes, although the magnitude of this risk is uncertain. So I included a couple of matched cohort studies here that attempt to quantify that increased risk of infection in our diabetic patients. So in the first study, in the top row here, this is a matched cohort study using a Canadian electronic medical record. And in this study, they found that the odds of any infection were higher among patients with diabetes compared to the matched cohorts. And in particular, diabetes was associated with skin and soft tissue infections, followed by genitourinary, gastrointestinal, and lastly, respiratory infections. In the second study by Carey and colleagues in 2018, this was also a retrospective cohort study using a primary care database in England. And they found that the incidence rate for any infection was higher among patients with type 2 diabetes compared to matched controls. And in this study, the most common infections were bone and joint, candidiasis, sepsis, and cellulitis. So it's well known that patients with diabetes are at increased risk of infection, and there are several factors that play into this increased risk, in part due to host factors as well as organism-specific factors. So host-specific factors that are thought to predispose diabetic patients to infection include the following. So first, we see hyperglycemia-related impairment of the immune response. So patients with diabetes have impaired neutrophil chemotaxis and adherence to vascular endothelium. They have impaired phagocytosis and cell-mediated immunity. All of these are depressed in our diabetic patients, and these increase with the degree of hyperglycemia. We also commonly see vascular insufficiency, which may result in local tissue ischemia that in turn enhances the growth of anaerobic organisms while also depressing the oxygen-dependent bactericidal function of our leukocytes. Patients with diabetes also commonly have sensory peripheral neuropathy, so they may experience minor local trauma, which can result in skin ulcers and in turn lead to diabetic foot infections. Diabetic patients also often have autonomic neuropathy, and they can develop urinary retention and stasis that in turn predisposes them to developing urinary tract infections. Patients with diabetes are also found to have greater skin and mucosal colonization with pathogens such as Staphylococcus aureus and Candida species. And this can predispose them to either cutaneous or incisional infections, as well as transient bacteremias, which can then result in infection at distal sites, such as damaged muscles. There are also several organism-specific factors that increase susceptibility to infection in our diabetic patients. We will focus on viral because obviously that's most pertinent to the COVID-19 disease. So recent findings do indicate that transient changes in systemic metabolism are induced by the immune system as a strategy against viral infection. So in our patients with type 2 diabetes, this system actually fails, thereby negatively impacting the antiviral immune response. As you can see in this image here, the normal protection against infection is mediated by specialized immune cells, but also by the innate abilities of the tissues to provide barriers against pathogens and also signal their infection to the immune system. So patients with diabetes experience impairments to properly respond to infection at almost all of these levels of control. So just to point out a few of the levels, for example, patients experience tissue damage and they have decreased immune cell access to their tissues. They also have hormonal dysfunction and metabolic disturbances and disbalances, which we previously talked about in detail. And once these diabetic patients are infected with a virus, they have an increased risk of progression to severe disease and worse outcomes. Some of the contributors to infection and severe disease include the fact that diabetes frequently coexists with cardiovascular disease and older age, which independently by themselves increase the risk of severe disease and poor outcomes. We also saw that poor glycemic control impairs the innate immune response, and that the presence of diabetic complications such as vascular insufficiency and peripheral neuropathy may also predispose these patients to infections, which is likely an indicator of poor disease control. We saw that in obese patients, they have a low-grade subclinical chronic inflammatory state due to increased secretion of adipose tissue hormones and cytokines that can contribute to the development of insulin resistance. And then lastly, patients with diabetes have been reported to have functional abnormalities in their respiratory tracts. For example, they've been found to have reduced lung function through low FEV1. They have reduced forced vital capacities and also peripheral airway obstructions. All of the aforementioned variables contribute to a chronic inflammatory state in our patients with diabetes and hypercoagulability, which have been documented in clinical studies. So I pulled this one that summarized the findings pretty well. And this study looked at about 175 patients with COVID, 25 of which had diabetes. And when comparing the patients with and without diabetes, all of which 18, and they did not have any other comorbidities, the authors found that inflammation-related biomarkers such as IL-6, C-reactive protein, serum ferritin, and coagulation indices such as D-dimer were all significantly higher in diabetic patients compared to those without diabetes, with a p-value of less than 0.01, suggesting that patients with diabetes are more susceptible to an inflammatory storm, which can eventually lead to rapid deterioration in COVID-19. So the second side of the coin is that patients with COVID-19 and no known history of diabetes are presenting with new onset diabetes and severe metabolic complications, including diabetic ketoacidosis. And we previously discussed the physiology behind metabolic disturbances in COVID and induction of beta cell dysfunction through those ACE2 receptors. However, viral infection associated inflammation and cytokine release also induce insulin resistance and contribute to new onset diabetes. So viral infection activates a type 1 immune response, resulting in the production of cytokines such as TNF, we see interferon, and interleukin 6, all of which induce transient insulin resistance in muscle and liver. The pancreas then compensates through increased secretion of insulin, which directly promotes the antiviral immune system. And this cycle continues over and over, leading to greater inflammation and greater peripheral insulin resistance. New onset diabetes has been documented in other chronic viral infections, including cytomegalovirus and hepatitis C. And several recent studies have reported new onset diabetes associated with COVID-19, as well as several anecdotal reports. I know that in my own practice, I've seen this as well. And these patients commonly present with complications such as diabetic ketoacidosis, and they're phenotypically described as both type 1 and type 2 diabetes. And this new onset diabetes is thought to be a combination of the pancreatic beta cell dysfunction that is induced by the virus itself binding to that ACE2 receptor, as well as the cytokine-induced insulin resistance from this chronic inflammatory state superimposed on the acute inflammation by the virus itself. So I'll pause here again with a quick true or false question. COVID-19 disease may induce new onset diabetes in a healthy individual with no known history of metabolic disease. Okay, perfect. It looks like just about everybody said true, which is correct. Just wanted to make sure everybody's awake because I know it's getting late. All right, so now that we've seen that COVID-19 can induce diabetes and lead to worse outcomes, let's move on and discuss some of the clinical consequences of these congruent disease states. So irrespective of COVID-19 or a viral illness, hyperglycemia by itself has numerous clinical consequences that have been very well documented in the literature, including impaired wound healing. We see increased risk of infection. We see decreased recovery after certain procedures. And I pulled this one study that showed a higher mortality after myocardial infarction. This came from the Cooperative Cardiovascular Project that looked at the outcomes of MI patients and demonstrated a significant increase in 30-day mortality and 1-year mortality with higher degrees of admission hyperglycemia. So it's very well known that hyperglycemia leads to worse outcomes, and it's no surprise that we see this translating into our COVID patients as well. Specifically in COVID-19 disease, hyperglycemia without a history of diabetes has been associated with higher mortality and severe prognosis. So this Italian study of 270 patients admitted with COVID found that hyperglycemia was independently associated with mortality with a hazards ratio of 1.8. And after stratification by glucose levels, mortality proportionally increased with the degree of hyperglycemia, as you can see demonstrated in this figure on the slide. Higher mortality rates have also been observed in patients with COVID-19 disease and pre-existing diabetes, and this has been very well documented. So I pulled a large meta-analysis of about 6,500 patients from 30 studies, that found that diabetic patients with COVID-19 were at an increased risk for death, severe COVID, acute respiratory distress syndrome, and disease progression with a cumulative relative risk of 2.12. Most concerningly, however, the risk of mortality appears to be higher in patients with new onset diabetes compared to COVID-19 patients with known diabetes. So in this retrospective study conducted from January through March of 2020 in Wuhan, China, they looked at 453 patients with severe COVID-19 disease, and patients were classified into 4 categories. They looked at patients with normal glucose, they looked at patients with hyperglycemia, which they defined as a fasting glucose of 101 to 124, and or a hemoglobin A1C between 5.7 to 6.4%. They looked at patients with a history of diabetes, and then those with newly diagnosed diabetes. And they found that patients with newly diagnosed diabetes had a higher mortality than COVID-19 patients with known diabetes, those with hyperglycemia, or those with normal glucose. And while we often question some of the data that came out of Wuhan in the early months of the COVID-19 pandemic, I chose to include this study because it's one of the few studies where hemoglobin A1C was measured on admission in these patients to determine whether diabetes was present prior to admission or whether patients developed diabetes during their admission. This is just a visual depiction of the previous results that we saw, and you can see depicted here that the cumulative hazard model of mortality according to different glucose categories among patients with COVID-19. And this model was adjusted for age, sex, smoking, systolic blood pressure, and total cholesterol, all of the different factors that we may expect to affect mortality. And as you can see, patients with the newly diagnosed diabetes had the highest cumulative hazard of mortality. So now that we've clearly established this population has a higher mortality, I think the good news is that we can actually reduce this risk through glycemic control. And that's kind of where pharmacists come in on the inpatient patient setting to help optimize the glycemic control and improve these patients' outcomes. So in a retrospective multi-centered study of about 7,000 cases of COVID in China, among which about 1,000 had pre-existing type 2 diabetes, they found that well-controlled blood glucose with a glycemic variability within 70 to 180 was associated with markedly lower mortality compared to those individuals with poorly controlled blood glucose. And the upper limit of glycemic variability in this study was greater than 180 milligrams per deciliter. And this was all during the patient's inpatient stay, just kind of proving that we can reduce mortality through excellent glycemic control in the hospital. So with that, we'll move on to our third polling question. Which of the following populations has the highest mortality rates in COVID-19 disease? Is it those with normal glucose, those with transient hyperglycemia, those with a history of diabetes, or those with new onset diabetes? Okay, perfect. It looks like the majority of people chose option D, or new onset diabetes, which is the correct answer. So patients who develop diabetes as a result of their COVID-19 infection have the highest mortality. So that's really the patient population who we want to be targeting to improve their outcomes. So throughout the rest of the presentation, we'll focus on exactly how to do that through glycemic control. So while there aren't any official guidelines released regarding the of diabetic patients with COVID-19, there were some guidance documents released in the early months of COVID-19 back in 2020 This one was published in the Lancet in June of 2020 and just provided some overarching guidance that can still be relevant today, including stratifying disease severity in order to help triage these patients, as well as determine which agents we should be utilizing for their management. Of course, optimizing their inpatient glycemic management using insulin as the mainstay of therapy. But again, as we'll see in a little bit, it kind of depends on how we stratify. Managing steroid-induced hyperglycemia will become very important, as we saw data from the recovery trials showing the role of dexamethasone in this patient population. Emerging data for oral agents, which is an area that's not as talked about, and we'll touch upon this, which oral agents we can use and when we should be using them. And then lastly, consistent and reliable glucose monitoring is emphasized for these patients, and we'll touch briefly upon the role of continuous glucose monitoring in this setting as well. So this is a simplified risk stratification model, and this is not at all to triage patients and determine the level of care that they should be receiving. It's more so to help us guide therapy and determine whether we should be using insulin, a combination of insulin orals, or if patients should just be continuing their home diabetic therapy. So patients with mild disease are considered to be those that are not hospitalized, and in very simplified terms, they can continue whatever they were taking prior to admission, their oral agents plus or minus insulin. For the purposes of this presentation, we'll consider moderately ill to be those that are hospitalized but not in the intensive care unit, for which we can use select oral agents and insulin. And then lastly, we'll consider severe patients to be those that are hospitalized in the intensive care unit, for which we will primarily utilize insulin to care for those patients. So in summary, the more severe disease, the more at risk a patient is going to be of adverse effects from oral agents. Therefore, for our severely ill patients, insulin will be the preferred therapy. So we'll start off by reviewing the ADA guidelines for inpatient glycemic control, as these can be generalized to our patients with COVID-19 as well. So once insulin therapy is started, a target glucose range of 140 to 180 is recommended for the majority of critically ill and non-critically ill patients. And more stringent goals such as 110 to 140 may be appropriate for select patients, and the guidelines state that those select patients may include cardiac surgery patients and patients with acute ischemic cardiac or neurologic events, only if they can be achieved without significant hypoglycemia. I included here a screenshot of the glucose tab within Epic, which is the electronic medical record that my institution uses. Just kind of a simplified model that I use to kind of gauge how much insulin my patient is receiving and what their corresponding glucose is, and kind of see if they're within that target range of 140 to 180. As a reminder of where these recommendations came from, they primarily came from the 2009 NICE sugar trial, which was conducted in our ICU population, where they compared intensive glycemic control with a target of 81 to 108 milligrams per deciliter compared to conventional glycemic control with a target of less than 180. And essentially they found that the conventional glycemic control, or the more lenient glucose target, resulted in lower mortality and lower rates of hypoglycemia for our ICU patients. And then just as a quick reminder, they generally chose this threshold of 180 milligrams per deciliter because this is the threshold for renal glucose excretion. So when the blood glucose level exceeds this, the proximal tubule of the kidney becomes saturated and begins to excrete glucose in the urine. So insulin is our preferred glycemic control agent for our hospitalized patient. And the choice of basal bolus versus continuous infusion depends on whether or not the patient is in an ICU. So the general guidance documents state that patients should be managed with individualized insulin therapy to achieve glycemic targets. And this can include the use of a correction scale, basal bolus, or continuous insulin infusions for patients who are in the ICU. Patients with COVID may have higher insulin requirements due to defects in their insulin secretion and frequent diarrhea and sepsis, leading to higher consumption of their endogenous insulin. And our primary goals of our insulin therapy are to reduce the contact frequency, so the amount of times that the nurse is going in the room to poke the patient's finger, get a finger stick. We want to reduce glucose variability, minimize the risk of hypoglycemia, and improve overall glycemic control. And as a brief review, we can tailor the patient's insulin therapy based on the time action profile of the various insulin analogs. So for our rapid acting insulins, we have aspart, lispro, and glulisine, all of which peak within 1 hour and last up to 4 hours. We have regular insulin, which peaks within 2 to 3 hours and lasts up to 8 hours. We have NPH, which peaks within 4 to 10 hours and lasts for up to 12 hours and is typically dosed twice a day. And then we have our long-acting insulins, such as detamir and glargine, which have minimal peaks and therefore cause less nocturnal hypoglycemia compared to NPH. And while there's no guidance documents to recommend specific dosing regimens for this patient population, some of the things that I take into consideration initiating patients on insulin, and this could be patients with or without COVID, just hyperglycemia in the inpatient setting in general. I take into consideration the patient's weight as well as their insulin sensitivity. So a typical weight-based total daily starting dose is going to be around 0.5 units per kilo divided into half basal and half bolus. I may start a little bit lower if I consider the patient to be insulin sensitive, such as they're a frail, thin, elderly patient, or if they have renal insufficiency. The average diabetic patient that may kind of fall in the middle may be a type 2 diabetic. And then lastly, we may want to start a little bit higher in a patient who's more likely to be insulin resistant, such as those with infection, steroids, pregnancy, or morbid obesity. Steroid-induced hyperglycemia is a unique subset of COVID-related hyperglycemia that has very specific management recommendations that are aimed at targeting the pharmacokinetic profiles of the steroids that are used. So one of the many immediate side effects of steroids includes steroid-induced hyperglycemia. And our glucose targets are the same as the general diabetic population. And this can be either new onset hyperglycemia or exacerbation of pre-existing diabetes. And glucocorticoids induce hyperglycemia through several mechanisms, some of which include an increase in peripheral insulin resistance. We see impaired insulin release from the beta cells. We see an increase in glucose production from the liver. And then lastly, we see catabolism of adipose and muscle tissue. For the management of steroid-induced hyperglycemia, insulin is our treatment of choice, and we tailor our insulin therapy to the pharmacokinetic profile of the corticosteroid that's being used. So the glucose effects mimic the onset, peak, and duration of the specific glucocorticoid that is being used. So for our short-acting hydrocortisone, our glucose peaks are commonly transient and self-limiting. So if insulin is required, a short-acting agent would be appropriate in this setting. For our intermediate-acting glucocorticoids, such as methylprednisolone or prednisone, given as a single dose in the morning, hyperglycemia develops slowly and continuously, lasting until the evening. So in this setting, a short or intermediate-acting basal insulin, such as detamir or NPH, is recommended. And then lastly, for our long-acting glucocorticoids, such as dexamethasone, which has a prolonged duration of action lasting greater than 24 hours, we can utilize intermediate-acting insulin, such as NPH, dosed twice a day, or detamir or glargine, which really nicely mimics that profile with minimal peak of the dexamethasone and would just have to be administered once daily. So in this setting for dexamethasone or steroid-induced hyperglycemia in COVID-19, glargine dosed once daily would be my preferred option. Initial data and guidelines during the early months of COVID suggested holding metformin and SGLT2 inhibitors secondary to the high risk of renal dysfunction and dehydration in acute illness. However, over the past 2 years, we've gained significant insight into the beneficial effects of certain anti-hyperglycemic agents in COVID. And again, it kind of relates back to stratifying that disease severity. So in our patients with mild COVID disease who are not hospitalized, again, they can essentially just continue whatever therapy or regimen they were taking. For our patients that are hospitalized on the general medicine floors with moderate COVID disease, we do have some data to support that we can utilize metformin and SGLT2 inhibitors as some of our first-line agents, and we'll discuss the data surrounding that a little bit later. And then lastly, for our patients who are in the ICU setting with severe COVID-19 disease, as previously mentioned, insulin will be our therapy of choice. We'll also discuss some of the data surrounding other oral agents, such as DPP-4 inhibitors, and kind of their role in this algorithm as well. So the non-insulin anti-hyperglycemic agents of primary interest include metformin, SGLT2 inhibitors, GLP-1 receptor agonists, as well as DPP-4 inhibitors, summarized here with some of their pros and cons. And I want to just preface this section by saying that this data does primarily come from retrospective studies, with results being confounded by indication, patient risk profile, and severity of disease. However, I do think it's encouraging that we have a lot of emerging data for these agents, especially in the inpatient setting. So for metformin, there's actually been some observational studies that have suggested it can stabilize that ACE2 receptor, inhibit host virus binding, protect the vasculature, and decrease virus maturation. However, metformin unfortunately does have several adverse effects, especially in the setting of those that are severely ill, such as the risk of dehydration, lactic acidosis, and acute kidney injury. SGLT2 inhibitors are also promising agents in this setting because they have been shown to reduce viral load and have positive effects on cardiovascular and renal function, as we've seen demonstrated over the past several years for other disease states. However, they are also associated with several negative effects, such as the risk of dehydration, euglycemic DKA, as well as acute kidney injury. GLP-1 receptor agonists are not as applicable in the inpatient setting because, unfortunately, they're not included on many hospitals' formularies, but they have been shown to have anti-inflammatory effects in COVID by improving endothelial dysfunction, as well as improving those cardiovascular and renal function. Some of the potential negative effects include gastrointestinal symptoms, especially in the hospitalized setting. And then lastly, DPP-4 inhibitors have been thought to block viral uptake as well as reduce inflammatory response, and they are very well tolerated. However, there was one study that showed worse outcomes in patients with diabetes receiving DPP-4 inhibitors, although this finding was likely due to confounding by indication. And there's been some reports that have since suggested improved clinical outcomes and a reduced risk of mortality in patients receiving DPP-4 inhibitor therapy. But I think the main benefit of the DPP-4s is that they're very well tolerated in this population, especially compared to some of the other oral agents. So metformin seems to be an effective therapy with pleiotropic effects in all phases of COVID-19 disease. And there's been 4 observational studies that have shown decreased mortality among individuals with home metformin use. Some of the mechanisms of benefit in COVID-19 disease include glycemic control and weight loss. So metformin is a highly efficacious anti-hyperglycemic agent. And as we previously saw, glycemic control improves outcomes. Metformin is also associated with weight loss, whereas obesity is a risk factor for poor outcomes in COVID. Metformin is thought to have immune modulatory effects. So in patients with and without diabetes, metformin has been shown to favorably alter inflammatory mediators such as interleukin-6 and TNF-alpha. Metformin also has lung protective effects, which have been demonstrated in vivo models that show that metformin is able to overcome anabolic metabolism, which promotes resolution of lung tissue damage. Metformin has also been shown to decrease endothelial injury due to an increase in response to acetylcholine, a decrease in insulin resistance, and a decrease in tissue plasminogen activating factor. And then lastly, there's evidence that metformin increases endosomal pH, thus reducing viral replication. It also increases phosphorylation and expression of that ACE2 receptor, which alter the extracellular domain and decrease the SARS-CoV-2 entry into cells. And while it's well established that SGLT2 inhibitors exert cardioprotective and renal protective effects in our patients with type 2 diabetes, heart failure with reduced ejection fraction, and chronic kidney disease, and more recently HFpEF as well, therefore, it's been hypothesized that SGLT2 inhibitors may actually be beneficial in patients with COVID who frequently develop cardiovascular complications, acute myocardial infarction, and/or acute kidney injury. So the DARE-19 trial is the only published randomized double-blind placebo-controlled trial of an oral glucose-lowering agent in patients hospitalized with COVID-19 with at least one cardiometabolic risk factor, including type 2 diabetes, cardiovascular disease, and/or mild to moderate chronic kidney disease. So this study excluded critically ill patients, and it suggested that dapagliflozin was safe and well tolerated, but did not result in a significant risk reduction in organ dysfunction or death, nor an improvement in clinical recovery. But of note, there was no significant difference between dapagliflozin and placebo group for many of the adverse effects of interest that we were concerned about in this population, such as acute kidney injury and DKA. So transitioning a little bit into the role of inpatient glucose monitoring, we saw that the guidelines recommend continuous and reliable glycemic monitoring, and they suggest every 2 to 4 hours, which can be fairly frequent in patients with COVID-19 who are on contact precautions. The fact that the nurse has to dress in full PPE every time they go in to do a finger stick. So this has kind of led to an emerging role for continuous glucose monitoring, or CGM, in the inpatient setting. And the goal is to preserve PPE as well as limit healthcare worker exposure by allowing employees to remotely monitor glucose in real time without entering the room. So it has the potential to reduce hypoglycemic episodes and improve glycemic control in hospitalized patients, which have been documented in the literature for just generalized inpatient use. However, we do have very limited experience in COVID-19 patients. It's recently been studied in some pilot studies, although the PPE use was not quantified, nor were any meaningful clinical outcomes. So this is just a future area of interest that you may see talked about a little bit more as kind of the next step in the COVID pandemic for these diabetic patients. And as the link between COVID and diabetes still has many unanswered questions, an international group of leading diabetes researchers have established a global registry of patients with COVID-19 related diabetes. And this registry will be expanded to include patients with pre-existing diabetes who present with severe acute metabolic disturbances. And it may also be used to investigate the features and pathogenesis of COVID-19 related diabetes and help us gain clues regarding how to appropriately care for these patients during and after the course of their COVID-19 disease, as well as kind of better classify these patients so we know how to take care of them. So as we wrap up our discussion here, we'll finish with more of a case-based question. So this is KS, a 58-year-old female with a past medical history of hypertension, hyperlipidemia, COPD, and obesity, who was admitted to the MICU for management of COVID-19 infection requiring ventilatory support. She is day 5 out of 10 of dexamethasone 6 milligrams IV daily, and the team is concerned for steroid-induced hyperglycemia. And you can see in this figure here that the dexamethasone was given around 8 a.m. and around 1800, the patient's glucose peaked to 352. And by the next morning, the glucose was back down to 207. So considering this information, which insulin analog would you recommend? Glargine daily, glargine BID, a Lispro correction scale, or NPH BID? Okay, great. Looks like over half of participants chose glargine daily, or A, which is the correct answer. So thinking back to the pharmacokinetic profile of dexamethasone, it's going to have a very prolonged duration of about 24 hours or longer. So we want to make sure the patient is covered for that full period. And by administering glargine once daily, we kind of mimic that pharmacokinetic profile with minimal peaks, thereby minimizing the patient's risk of hypoglycemia. So to summarize our discussion today, I saw that the SARS-CoV-2 virus induces significant metabolic disturbances through the RAS system as well as the ACE2 receptor, and that patients with diabetes are at an increased risk of severe disease, whereas patients with COVID and no known history of diabetes are also presenting with new onset diabetes. Although diabetes and hyperglycemia are independent predictors of mortality in COVID-19, these risks can be significantly reduced through glycemic control. And insulin in combination with select oral agents are the mainstays of therapy for hyperglycemia management in COVID-19. So I want to thank you all so much for your attention this evening. And at this point, I would be happy to answer any questions.
All right, if anyone has any questions they would like to ask Dr. Shannon, you can direct them to the chat. I am not currently seeing any. All right, I don't see any in the chat. I did have one question, Dr. Shannon. You had mentioned continuous glucose monitoring as a potential sort of in this population. Is that something that you're doing at your institution at all in these patients?
So currently, no. When I was doing my PGY2 residency at one of the sites I was working at, they did attempt to pilot continuous glucose monitoring during the peak of the pandemic back in 2020. However, due to primarily cost reasons, as well as issues getting these devices reimbursed by insurances, I think it kind of fizzled out over the course of a couple of months. But I'm definitely talking with the hospitalists on my unit and also the endocrinologist and seeing if this is something that we can potentially start up again now that, you know, the numbers are a little bit lower and we have a little bit more time on our hands.
Okay, thank you.
Of course.
I do not see any other questions in the chat. If you, anyone on the call thinks of any, feel free to email them to the office and we can make sure that Dr. Shannon gets them so she can respond to them at a later date. And with that, I will turn it over to Dr. Studlak for her presentation.
Okay, thank you very much. So thank you for continuing to listen. We'll hear a few commonalities between the last presentation and this one. So it's nice to see that we're seeing some agreement between inpatient considerations with COVID and just inpatient considerations in general. So some of the things that we've already gone over, we'll see again. I have nothing to disclose. My objectives for the presentation are to define glycemic targets for hospitalized adults and describe the evidence supporting them, identify a strategy for achieving optimal glycemic control in hospitalized adults with diabetes mellitus, and to describe the management of non-insulin anti-hyperglycemic medications in the inpatient setting. So we'll start out with a polling question. So hopefully you are all paying very close attention to Dr. Shannon's presentation. So which of the following is the most appropriate blood glucose target for most hospitalized patients on a general medicine service? Is it A, 80 to 130 milligrams per deciliter, B, 90 to 110, C, 120 to 140, or D, 140 to 180 milligrams per deciliter? Okay, so it seems like most of our audience had selected D, which is 140 to 180 milligrams per deciliter, which is correct. And then we see 80 to 130, which we know is our fasting blood glucose target per the ADA. And we do have some more lenient goals for the inpatient setting, which we'll go over now. A little bit of background before we delve into glycemic control. So it's estimated that more than 10% of the US population have diabetes, and it's estimated that about 25% of hospitalized patients are diabetic. So this is a large proportion of patients that we see in our outpatient setting, and then we know a large proportion of our patients that we see on the inpatient side as well. It's estimated that about 40% of hospitalized patients experience hyperglycemia, which is defined as a blood glucose of over 140 milligrams per deciliter. So we're seeing hyperglycemia in not just our diabetic patients, but also patients that are admitted to the hospital that have other things going on, such as COVID, that may not be diagnosed with diabetes. But we are seeing hyperglycemia in that patient population as well. And we know this is bad because dysglycemia, so either hyper or hypoglycemia, has been associated with increased morbidity and mortality. So we know that our patients with diabetes often have comorbidities like heart failure, cardiovascular disease, COPD, but hypo and hyperglycemia are independent predictors of in-hospital mortality. And specifically, newly found or newly diagnosed hyperglycemia is a very strong independent predictor of in-hospital mortality. So we should care because this is going to be a large proportion of the patients that we see in our inpatient setting, and it's leading to bad outcomes. So number one reason that we should care is for our patients and for their general well-being. Other reasons that we might care are readmission rates. So we know readmission rates are a very hot topic, and readmission rates for patients with diabetes are almost double of those without diabetes. And you might care in the future, or your institutions might care in the future if they don't already, because CMS are adding 2 new electronic clinical quality measures in 2023. So this might impact reimbursement at your institution. So they're going to be monitoring for severe hypoglycemia, which they define as a blood sugar of less than 40 milligrams per deciliter within 24 hours of receiving an anti-hyperglycemic agent. So they'll be looking at the proportion of patients that have severe hypoglycemia. They'll also be looking at hyperglycemia, which are the number of days in which patients had a blood glucose of over 300 milligrams per deciliter. So we're seeing, this is a large proportion of the patients that are being admitted to the hospital, but then we're also on the back end seeing that the payment structure for the institution is probably going to be affected So if we're looking for ways to become involved and have some, funding behind getting positions added or different protocols that we're trying to get on the table, this might help to incentivize some of those programs. So some of the reasons that we see hyperglycemia in the inpatient setting, especially in higher rates than we see in the outpatient setting, are because of some relative deficiencies in insulin and then increased counter-regulatory hormones that happen when patients are admitted and they have illness that's going on. So we can see hyperglycemia that happens in patients that don't have diabetes. We can see iatrogenic hyperglycemia, like when we're giving patients dextrose, or like Dr. Shannon had mentioned, we're giving patients glucocorticoids, and we'll talk a little bit about glucocorticoids at the end as well. So we're seeing increased rates of hyperglycemia for iatrogenic reasons that we're causing, but also counter-regulatory reasons just due to what's going on in the patient's body with whatever illness that they're trying to fight off. So in terms of glycemic targets and technology, Dr. Shannon had gone over the NICE sugar trial, so we'll just go over it briefly again. But the NICE sugar trial really has defined glycemic targets and is really what we refer back to when we're talking about glycemic targets for our inpatients. So this trial specifically compared strict and conventional glucose control in critically ill patients. And so I won't be talking about critically ill patients in this presentation, but we don't have a wealth of data for our internal medicine surgical patients. So we've extrapolated a lot of the data from the NICE sugar trial. And so they defined strict glucose control as 81 to 108, and then conventional glucose control is less than 180. They looked at all-cause mortality at 90 days, and they found that the intensive glucose control was associated with higher all-cause mortality, and then also higher rates of severe hypoglycemia, which they defined as a blood glucose of less than 40. And so you can see the rates here. All-cause mortality was 27.5% in the intensive control group, and then 24.9% in the conventional glucose control group. And then the rates of severe hypoglycemia were, very different between those two groups. And we know hypoglycemia is an independent predictor of in-hospital mortality. And then on the chart on the right-hand side, you can see where those really diverge. So the primary outcome was 90-day mortality, but we can really see those lines start to diverge, around 3 weeks after randomization. So like I had mentioned, we don't have a ton of data, a ton of randomized control trials that are specifically looking at glycemic control in the medicine patient population on our internal medicine floors. But data from the NICE sugar trial really has historically been extrapolated to our non-critically ill patients. And so this target of 140 to 180 has been endorsed by the American Diabetes Association and the Endocrine Society for most non-critically ill patients. And so the guidelines do recognize that there are instances where stricter blood glucose control might be acceptable, and they specifically mentioned those undergoing cardiothoracic surgery. And so there's a thought that there are decreased rates of, sternotomy infection in patients undergoing coronary artery bypass grafting or any other type of open heart surgery, although the data doesn't necessarily support very strict blood sugar control in that patient population. And then there's also room for more lenient blood glucose control. So especially in those that might be at increased risk of hypoglycemia, and they just recognize that your clinical judgment should be employed. So there's never an instance where we should just follow something because that's what the guidelines say. We always have to use our clinical judgment. So we may have very elderly, very frail patients who are at increased risk of hypoglycemia, and we may accept that they are going to run a little bit high, or we may have patients who are more palliative care patients, and they're not quite at the end of life comfort care, but we don't necessarily need to chase those super strict blood sugars while they're in the hospital. In terms of some of the technology that exists for glycemic testing, so traditionally we use point of care testing. So the American Diabetes Association recommends that the bedside point of care blood glucose testing be performed before meals or every 4 to 6 hours for those patients that aren't eating. We know that there are several limitations to this point of care testing. So there's variability in the measurement compared to a blood draw. So the point of care testing, the finger stick that's being done is using capillary blood. So typically that postprandial capillary blood is higher in glucose than venous blood. So if you were to draw a venous blood sample and use a finger stick and compare those two, the finger stick might be a little bit higher than your venous blood. In terms of fasting blood, this difference isn't as stark. So if you were to draw a venous blood sample for a fasting time and then also do a point of care test for a fasting, there's not as much of a difference, but when after patients eat is typically when that difference is highest. So there is some variability to that point of care testing. There may also be interference from comorbid conditions. So patients that might be dehydrated or hypoxemic or may not be perfusing to their extremities, their point of care finger sticks may not be accurate. So we need to recognize if the numbers that we're getting aren't making sense, there might be some interference that we're getting, and we might need to employ a different method of obtaining that patient's blood glucose, like a venous blood draw. There are inherent issues with point of care testing as well. So Dr. Shannon had mentioned trying to reserve PPE for our COVID patients, and we'll talk about CGMs actually here in a minute as well. So this requires, the nurse to go into the bedside to prick the finger, to get the blood samples. Hopefully that glucometer talks with your electronic medical record and those results go right in. But sometimes it requires that the nurse, release those results into the EMR. So this is, time consuming and uncomfortable for patients as well. All right, so our second polling question, which was actually Colin's question to Dr. Shannon, I'm also interested to know, does your institution use continuous glucose monitoring or CGM in their management of hyperglycemia in the inpatient setting? So yes, no, but maybe looking to implement soon. No, you don't, or are you unsure? Okay, so similar results to what I was expecting. So actually a few people are using CGM, which is very interesting. A couple say no, but looking to implement soon. The majority are saying no, they do not use CGM, and then a few that are unsure. So the institution that I work at also does not use CGM, but it would be interesting to try to get something put into place. So CGM, or continuous glucose monitoring, provides frequent interstitial glucose levels. We've heard a lot about CGMs in the recent years, specifically in the outpatient setting for patients who may be on multiple daily injections or continuous subcutaneous insulin. So there's a lot of data that supports CGM in that patient population in the ambulatory care setting, but there's really not a lot of data that supports using CGM in the inpatient setting. So there was a study that I looked at by Holzinger and colleagues that looked at 124 critically ill patients, so not a very large trial. And these patients were receiving mechanical ventilation in the ICU. And they saw that CGM was associated with lower rates of severe hypoglycemia and an absolute risk reduction of severe hypoglycemia of about 10%. So like I mentioned, we don't have a lot of data on the inpatient side. So for those of you that might be using CGMs on the inpatient side, or for those of you that are looking to implement that soon, I definitely encourage you to do so, and then to publish that data or present it maybe at our conference in the spring. It would be very interesting to see that data. So in the era of COVID-19, CGM might be an opportunity for some of that reduced staff exposure. So saving some PPM, saving staff exposure from having to go into the room to collect a point of care blood glucose. And we have that data that's available, right from that CGM itself. So moving on to insulin therapy. So as was mentioned by Dr. Shannon, insulin is really our mainstay of therapy for the management of hyperglycemia in the inpatient setting. So the American Diabetes Association has several recommendations that they make regarding insulin therapy. So insulin is the preferred agent for management of hyperglycemia in hospitalized patients. They also recommend that insulin therapy be initiated for patients with persistent hyperglycemia, and they define persistent hyperglycemia as a blood glucose of 180 milligrams per deciliter or more on more than one occasion. And they also make a statement that use of bolus correction insulin or sliding scale insulin only is very strongly discouraged. They recommend that patients with poor oral intake or those who are taking nothing by mouth should receive both basal insulin or basal plus bolus correction, and that patients with good oral intake should receive basal, prandial, which is nutritional, and correction insulin. The Endocrine Society, which also publishes guidelines, makes similar recommendations. So insulin is the preferred agent. They also recommend that scheduled insulin therapy should be initiated for patients with persistent hyperglycemia, and they have the same definition for persistent hyperglycemia. But they state that correctional insulin can be initiated for patients with mild hyperglycemia, and so correctional or sliding scale only for patients with mild hyperglycemia. So a little bit of a discordant recommendation, but for a very specific patient population for this correctional insulin only. So Dr. Shannon had also reviewed insulin pharmacokinetics. So we'll kind of go through this relatively quickly, but just as a review, we have several forms of insulin. So rapid acting, short acting, intermediate acting, long acting, and then ultra long acting. And so it's important to note the type of insulin that's being recommended and when you can generally expect to see the onset and the peak, as well as the duration of the type of insulin that we're using. So correctional insulin is also known as sliding scale insulin or rainbow coverage insulin. I think we've all heard, multiple times over our pharmacy, school, as well as the training in our careers, that we should not be using just sliding scale insulin. And yet I think, the majority of us that work on the inpatient side probably see only sliding scale insulin in inpatients still happening. So where does this recommendation for not using correctional insulin come from? So this, for those of us that aren't familiar with correctional insulin or sliding scale insulin or rainbow coverage, this is the use of rapid acting or regular insulin. So going back to the slide before, this is insulin lispro, aspart, or glulisine, or regular insulin. And then this is based on preprandial blood glucose readings. So point of care blood glucose readings that are taken before patients are eating or every 4 to 6 hours for patients who are NPO. So this recommendation for not using sliding scale insulin or correctional insulin really comes from a 2011 study by Pierres and colleagues who found that patients had reduced rates of hospital complications if they were treated with basal bolus insulin compared to sliding scale insulin. They also saw increased rates of hypoglycemia. So this was a very small study. The N was 211. So they saw better glucose control, but they also saw increased rates of hypoglycemia. So if you look at the guidelines, the ADA guidelines, this is actually the study that they cite, this 211 numbered study. There was also a Cochrane review that was published in 2018, and they compared, they really looked at all of the correctional insulin or sliding scale insulin studies that were published. And they found that basal bolus scheduled insulin therapy was associated with lower average blood glucoses compared to sliding scale. So yes, patients achieved better glycemic control with basal bolus compared to sliding scale. But conversely, they also found that basal bolus insulin was associated with a longer length of stay and increased rates of hypoglycemic episodes. So I think that when we are looking at the recommendations that are coming from the guidelines, we have to look at the evidence that's behind them as well. And so even though we know that we are probably overusing this sliding scale or correctional insulin, there are, instances in which it might be appropriate for patients. So in patients that might have an increased risk of hypoglycemia, we should really be evaluating the overall patient and recognizing that the evidence that exists for sliding scale insulin really isn't great. So yes, we really should be utilizing basal insulin wherever we can, but the evidence behind not using correctional or sliding scale insulin unfortunately isn't great. So we have a patient who is admitted to the hospital and we need to select an insulin dose for them. Basically, the guidelines recommend to continue patients on their home regimen. So if patients are on insulin at home, they're well controlled and they're expected to continue to eat a normal diet while they're in the hospital, you can continue their outpatient insulin regimen. They also say that to consider a dose reduction of about 10 to 20% in patients who are on what they call a basal heavy insulin regimen. So these are patients who require more than 0.6 units per kg per day of basal insulin only. And then you can also consider a dose reduction of 25 to 50% to account for a reduced nutritional intake in patients who are at risk for hypoglycemia. So these might be patients who are elderly, who have some sort of renal dysfunction, who might be on this basal heavy regimen. Perhaps at home, they eat a terrible diet and they come into the hospital and we put them on a carbohydrate restricted diet. So in general, we should consider continuing their home dose as long as they're relatively well controlled. But if we expect their diet in the hospital to be, very different from what they normally take at home, we should consider a dose reduction somewhere between 25 to 50%. If we have a patient who maybe doesn't require insulin at home and they're diet controlled, or they're on oral anti-hyperglycemics, or perhaps they have poorly controlled diabetes despite being on insulin as an outpatient, we should perform a calculation. So every patient should receive a weight-based total daily dose of insulin. And I'll go over what some of those recommendations are, which I know Dr. Shannon did during her presentation as well. So in general, we need to look at the clinical characteristics of the patient. So I know Dr. Shannon had mentioned it's generally a range. So somewhere between 0.2 to 0.5 units per kilogram as the total daily dose. In general, if you have a lean patient, an elderly patient, or someone with advanced kidney or liver disease, you can edge towards the lower end of that range, so 0.2 to 0.3. Most of our patients that have a normal BMI are going to be used as 0.3 to 0.4. And then our obese or overweight patients need a higher total daily dose of insulin, so 0.4 to 0.5 units per kg. We would then want to divide that total daily dose 50 to 70% as basal therapy, and then 30 to 50% as preprandial bolus divided into 3 meals. So I think we are familiar with our weight-based calculations of insulin. We can find that information in some of our resources like LexiComp, but where I think a lot of us struggle is how to titrate insulin on the inpatient side. So we know that we have this target for most patients of 140 to 180. How do we achieve that, that goal in patients who we've started them on a weight-based insulin dose, but we're still not achieving our goal blood sugar? So in general, if fasting blood glucoses are still high and they're over 180 milligrams per deciliter, the recommendation is to increase basal insulin by about 10 to 20% every 2 to 3 days. And so we know that insulin is a large molecule, and it might hang around for longer than we intend it to. And so we don't necessarily need to be making large changes every day. We can increase that basal dose by about 10 to 20%, and we don't want to do it more frequently than every 2 to 3 days. If our postprandial blood glucoses are over 180, we can increase our prandial insulin by about 1 to 2 units per dose, and we can titrate this a little bit more quickly because of the short half-life of our rapid-acting and short-acting insulins. So 1 to 2 units per dose every 1 to 2 days. And then if any blood glucose is less than 80, we want to reduce our total daily insulin by about 20%. So moving on to some of our special populations. So corticosteroid use. So Dr. Shannon had mentioned the use of dexamethasone in our COVID-19 patients, and we're obviously seeing, high rates of hyperglycemia with our corticosteroid use, especially with our COVID-19 patients who have multiple reasons to be hyperglycemic. It's estimated that somewhere between 30 and 80%, depending on where you look, of our hospitalized patients that are receiving supraphysiologic doses or higher doses of glucocorticoids or GC experience something called glucocorticoid-induced hyperglycemia. So patients with glucocorticoid-induced hyperglycemia have higher rates of mortality, cardiovascular events, and infection. So this is something that we can't say, oh, they're on a glucocorticoid, it'll be gone in a couple days. We can ignore those high blood sugars for a few days. We know that hyperglycemia is an independent predictor of increased in-hospital mortality, and then also glucocorticoid-induced hyperglycemia can also increase in-hospital mortality. So NPH insulin is an option for management of GC-induced hyperglycemia, and that's because we see similar onset and duration of action with NPH in some of our intermediate-acting corticosteroids, so prednisone, prednisolone, and methylprednisolone. And just like we are going to initiate insulin and intensify our insulin regimens for patients that might be receiving corticosteroids, hopefully we have the ability to taper off or discontinue those glucocorticoids after a few days. We have to remember to readjust those insulin regimens once those glucocorticoids are tapered off or also discontinued. So this is a protocol that I had found in the Society for Hospital Medicine or the Journal of Clinical Medicine that looks at management of glucocorticoid-induced hyperglycemia or systemic steroid-induced hyperglycemia. So this is looking at the specific corticosteroid that's being used. So you can see hydrocortisone is on the top. So I'm not sure if you're able to see my mouse, but where you see that letter A is hydrocortisone. Prednisolone is one of our intermediate acting, and then Dr. Shannon had mentioned dexamethasone is a longer acting. So this is looking at using different insulins to kind of try to mimic the peak that we're seeing with the different corticosteroids that we're using. And so I thought this was a nice resource to have to help manage our glucocorticoid-induced hyperglycemia. And you can see on here a mix of recommendations. So we see NPH insulin used for our intermediate acting glucocorticoids like prednisolone or methylprednisolone or prednisone, and then NPH insulin twice a day or a basal insulin like glargine being recommended for some of our longer acting corticosteroids like dexamethasone. So the next special population type that we'll talk about are patients that are receiving insulin pump therapy. So we do have both type 1 and type 2 patients who receive an insulin pump or maybe on an insulin pump before they come to the hospital. So the general recommendation is that patients who are receiving continuous subcutaneous insulin via an insulin pump should continue that therapy in the hospital whenever they're able to. Obviously, we'll have patients who are not able to continue that therapy. So if patients don't have the ability to adjust those pump settings, patients who maybe are critically ill, patients who may have altered mental status, we should discontinue that and then transition them over to basal bolus subcutaneous insulin. So an effort needs to be made when the patient comes in on that insulin pump, and we need to transition them over to basal bolus so that we can create an appropriate regimen for them. So a lot of times this involves contacting the patient's endocrinologist or maybe a pharmacist that helps to manage that patient's insulin pump. At least in my experience in talking to patients that are on insulin pumps, they either know exactly the number of units that they use, the rate that it goes in, how many hours it infuses over, or they have absolutely no idea, and there's never an in-between. So it's good to always double check those rates so that we can get an idea of how many total units that patient is using on a daily basis to help us determine how many units they'll need for basal coverage and how many units they will need for bolus coverage. Hopefully your institution should have some sort of policy or procedure in place for patients that do have an insulin pump. And so they'll likely have to sign some sort of consent to manage their own pump. We'll have to record their blood sugars. We typically will have a log or some sort of flow sheet in our EMR for those blood sugars to be recorded on, just to make sure that we are achieving appropriate numbers while they're in the hospital. We also often come across patients that are NPO or nil pro. So patients that are not eating should have their blood glucose monitored every 4 to 6 hours. Obviously, nutritional insulin should not be administered. So, they will not be receiving a meal and should not be receiving their mealtime insulin. Correctional and basal insulins should continue. And basal insulin really should not cause hypoglycemia. So as long as we have them on a good regimen, we haven't seen any hypoglycemia with the regimen that they're on before making them NPO. Really no change needs to be made to that basal insulin regimen. You can consider a 25% dose reduction for patients that are at risk of hypoglycemia. So again, similar to the patient populations we've talked about before. So elderly patients, those with significant renal or liver impairment, and then those with a basal heavy regimen. I think the default for a lot of the providers that I see are either to have the dose or to hold it entirely. And then for the day that they have surgery, their blood sugars look okay, and the providers kind of pat themselves on the back and they think that they've done the right thing. But then we see the ramifications of either holding that dose or reducing that dose by too much a day or two after they've had that procedure, or whatever reason they were NPO, and then we end up having to chase our tails again. So, being cognizant of when patients are NPO and the reductions that are being made, and really making an intervention that, or educating the provider that we really don't need to change the basal insulin for these patients can make a big difference. So moving on to our non-insulin anti-hyperglycemics. So the last polling question I have, does your institution have a protocol that utilizes non-insulin anti-hyperglycemics for patients with diabetes in the inpatient setting? So yes, no, or you're unsure. Okay, so a few say yes, most of us say no, and a few of us are unsure. So going through a few options of our oral anti-hyperglycemics and some of the evidence that we have to use them in the inpatient setting, we'll start with our DPP-4 or dipeptidylpeptidase 4 inhibitors. So these medications reduce postprandial glucose by enhancing endogenous prandial insulin secretion and inhibiting glucagon secretion. They are relatively well tolerated in terms of side effects, and they are also associated with relatively low rates of hypoglycemia. So this makes them potentially favorable for use in the inpatient setting. So there have been a few studies that have looked at use of DPP-4 inhibitors in the inpatient setting. So a study that I had looked at by Ampieres and colleagues that looked at sitagliptin alone, sitagliptin plus insulin glargine, and then traditional basal bolus insulin in 90 patients. The authors really found no difference in outcomes, and the primary outcome for this study was incidence of hyperglycemia, but obviously patients received less subcutaneous injections. So we do see the potential to use DPP-4 inhibitors in our inpatient patients, so something like sitagliptin or linagliptin. We also have our GLP-1 agonists. So our glucagon-like peptide-1 agonists, we know that they have multiple mechanisms of action, and trials have suggested a modest decrease in hypoglycemia with GLP-1 agonists compared to traditional basal bolus therapy. So there have been a few studies that have looked at use of GLP-1 in the inpatient setting. So one study by Faithman and colleagues compared exenatide plus basal insulin, and then basal bolus insulin in 150 hospitalized patients. And they found that exenatide alone or in combination with basal insulin resulted in a higher proportion of patients reaching target blood glucose. But like Dr. Shannon had mentioned during her presentation, many of us don't have GLP-1 agonists on our formularies in the hospital. And we know that a significant side effect of GLP-1 is gastrointestinal side effects, especially early on in the initiation of these agents. And so that might limit our ability to implement these agents on the inpatient side. And then, of course, metformin. So we know metformin is a biguanide anti-hyperglycemic agent. It decreases hepatic glucose production, it decreases intestinal absorption of glucose, and increases peripheral insulin sensitivity. So recommendations from our leading organizations are to hold any oral anti-hyperglycemic agents, and this includes metformin. They recommend this especially in our patients that are at risk for lactic acidosis, so those who might be at risk for anaerobic metabolism, including sepsis and hypoxia, those with renal dysfunction, those with impaired clearance of lactic acid, such as liver failure, and then those who are going to receive iodinated contrast media and have a GFR of less than 60, really should not be receiving metformin. But we do have the potential to use metformin in patients who potentially aren't at risk for lactic acidosis. But in general, the consensus is to hold all oral anti-hyperglycemic agents. And so we'll finish on opportunities for pharmacists. So several opportunities, I think, exist for pharmacists in the management of hyperglycemia on the inpatient side. As you could see through the presentation, there are several small studies that have been published, but not a ton really exists in the management of hyperglycemia outside of the critical care setting. There have been a few studies that have been published that looked at pharmacist involvement on a consult-driven diabetes management team. And so there's not much data that exists that looks at specific pharmacist involvement in management of inpatient hyperglycemia, but this would be in collaboration with an endocrinologist, a provider like an NP or an MD, typically a diabetes educator, and a consult is put in, and this team goes and helps manage the patient while they're in the hospital, and they tend to see positive outcomes associated with this multi-factorial involvement on the inpatient side. there's obviously, opportunity for pharmacy to help manage these patients on the inpatient side. There's also an opportunity for pharmacists to dose and adjust insulin. So again, not much data really exists in patients outside of the critical care setting. There is a study that was published that looked at transitioning from IV insulin to sub-Q insulin in patients that are moving from the critical care setting to the general medicine floor setting, and found that pharmacists are able to help manage that transition. We can also help with dose adjustments for hyper or hypoglycemia following some sort of approved protocol that's been put in place. So the institution that I work at does have a protocol such as this. But again, not much exists in the literature for us to be able to use. But we do see, if you look, there are several institutions that have published their dosing protocols for insulin. So there's definitely an opportunity for us to collaborate with our physician teams in creating an approved protocol for us to utilize in helping to manage these patients, especially if we're going to be seeing reimbursement affected by patients that have hypo or hyperglycemia. And we know we're already seeing increased rates of readmission in this patient population. And then, of course, transitions of care. So medication procurement, there are a lot of insulins that are available. In the last several years, there have been several new brands of insulin that have come out for the different long-acting and short-acting formulations. This can be very confusing for providers and patients. So trying to understand what insulins are on a patient's formulary, and really helping to help the patient get that medication and making sure that that is what's covered on their formulary. Testing supplies. So I know that physicians, when they have to send a new glucometer and testing supplies, or they have to send new insulin pens and needles, it gets very confusing. So making sure that there's some sort of order set that's built, or you're there to be able to help them in making sure that the patients are going home with everything that they need, making sure that we're picking the right supplies and glucometers for them to go home with. Obviously, discharge counseling. So we know that pharmacists' involvement in transitions of care has led to improved outcomes in various patient populations, including heart failure, patients with acute coronary syndromes. Really not much exists in terms of literature for transitions of care for our diabetic patient population. So if you're involved in transitions of care, I would encourage you to consider some sort of research project looking at transitions of care for diabetic patients and maybe looking to present that data. And then communication with our outpatient providers. So if we are changing insulin therapy for whatever reason, if we're adding a new medication, decreasing doses, making sure that that is communicated with our outpatient providers. So if a patient is following with a primary care provider and an endocrinologist, helping to get that information communicated. Maybe they're following with a pharmacist that's doing CDTM, and so a good opportunity for some pharmacist to pharmacist communication in the outpatient setting. So a lot of opportunities, I think, exist for pharmacists. So some conclusions that I'll end with. So inpatient dysglycemia, we know, is a common occurrence. It does have significant potential ramifications, including increase in hospital mortality. Inpatient dysglycemia may also impact reimbursement for your institution. So this might be something that you can use and take to your C-suite if you're interested in getting involved in some sort of protocol or looking at transitions of care for your institution. We know that insulin remains the standard of care for management of inpatient hyperglycemia. Point of care blood glucose testing remains commonplace, but we might see an implementation of CGM in the inpatient setting in the near future. It sounds like some of our colleagues across the state are seeing CGM implemented or might be seeing CGM implemented in the near future. And then pharmacists are uniquely qualified to assist in the management of these complex patients and medication regimens. I'd like to thank you all for your attention, and I will take any questions.
I do have a few questions that came in through the chat. So the first one is, what are some resources to use to educate pharmacists on continuous sub-Q pumps and dose adjustments in these types of patients?
Yeah, excellent question. So resources for PharmDs on continuous sub-Q pumps. I think our best resource is probably ourselves. I am not an expert in any means on these on insulin pumps, but I have on several occasions reached out to my ambulatory care colleagues. So if in your area you have pharmacists that work in an endocrinology clinic that help to manage these pumps, they are always the first person that I call to help me manage these pumps. So honestly, usually the patient knows more about their pumps than the physicians in the hospital do. So reaching out to an outpatient pharmacist that might deal with this on a daily basis, I think is probably your best bet in terms of specifically for a patient. But also I think if you're interested in having some education for maybe your department or for your institution in general, maybe reaching out to an outpatient provider that helps to, that deals with these pumps and CGMs on a regular basis, I think would be a great idea.
Excellent. One more question. What have you seen in terms of continuous glucose monitoring for non-critical care in patients? Any devices you've seen used successfully?
Great question. And unfortunately, I have not. So I've not ever seen CGM used in the inpatient setting where I am. We have patients that come in that have CGMs all the time, but usually they get taken off either in the ambulance or the ER, and then the patient's family takes them home. Unfortunately, we know CGMs are associated with great outcomes on the outpatient side, but I feel like usually this translates to the patient not knowing their doses, and so it can make management of their blood sugar really tricky, especially in that first 24-hour period. So we do not have a protocol for using CGM in our inpatients, but I think that's something that we need to look to do in the future, because I think we're going to be seeing a lot more of these devices.
Thank you. That was the last of the questions that I have in the chat. We're a little bit ahead of schedule, so if anyone has any other questions, go ahead and ask now. Okay, seeing none, we